Alaikum warahmatullah. Thank you for invitation for me for that presentation. My talk will be for non-invasive imaging and tools that can get a benefit for diagnosis of peripheral arterial disease, mostly in diabetic patients. The tools, we can use it in the clinic or we can use it in the radiology department. So as we all know, the peripheral arterial disease is a vascular disease affecting the large and growing also percentage of population worldwide. We have two kinds of evaluation, either imaging or tools, can reflect physiological and morphological informations. The physiological information can do in the clinic mostly is ABI, ankle brachial index, and pulse volume recording. And for morphological information, we can do CT and MRA. And the most important tool for evaluation of both physiological and morphological information is the ultrasound, arterial duplex ultrasound. So I will go more for arterial duplex ultrasound, since it is the most informative tool for evaluation of peripheral artery disease. So regarding the anatomy of the lower limb, usually from aorta to the two, most of us is familiar with that, starting with iliac, common iliac artery, external and internal artery. External will go to for common femoral artery. Clinically, usually we are starting the start of common femoral artery start at the inguinal line. But for the endovascular treatment, we have other marker, which is the inferior epigastric artery. We can distinguish the takeoff of the common femoral artery from the external iliac artery. Common femoral artery, it will bifurcate into deep femoral and superficial femoral artery. Then we can the superficial femoral artery take off of the popliteal artery at the site of adductor canal, which is difficult to assess at this area, especially for obese patients. So for evaluation of such artery, they divide it into 3 segments. Usually our marker is the, if we do it in angiograph in the frontal or AB view, start of the edge of the distal femur till the upper edge of the patella. Then the second segmented from the upper patella to the mid of knee joint. Then the third segment from the knee joint till the bifurcate, in which it will bifurcate into the anterior tibial and tibio-peroneal trunk. Then tibio-peroneal trunk divided into posterior tibial and peroneal arteries. So that landmark is important, especially for endovascular treatment, because we are usually for endovascular treatment, we have different management for popliteal artery stenting or angioplasty, different from the superficial femoral artery. Simply how to distinguish between artery and vein in ultrasound. Usually for artery, it is smaller than the vein, and also it is rounded in shape, while the vein is oval shaped. Other feature we can easier distinguish the artery from the vein is the compressibility. We can see the vein after compression, it is disappeared in this image. This is a simple way to distinguish between both. Visibility of wall, usually we can see it, especially in atherosclerotic patient. It can be seen in the artery, but vein usually invisible. Usually we are using specific types of probes for to evaluate the lower limb arteries. Most of the patient evaluated by linear probe with frequency of 9 to 15 frequency, but sometimes we need to use curvilinear, especially in obese patient, and also we need it for evaluation of iliac arteries. Also, we have higher frequency probes, for example, called hockey stick. It can reach to 15. Usually, we are using this for pedal arteries. The pathway or the way to evaluate the lower limb arteries, as seen in this picture, for the common femoral and proximal superficial femoral arteries, we can see the transverse 1 and 2 in these images. This is what we will see in ultrasound. And at the bifurcation, we can see superficial artery and deep superficial femoral artery and deep femoral artery as in transverse image. While in the longitudinal, we have to see it as it is not appearing this. In 3, we can see it as Y-shaped appearance. I don't know if we can remove this or take it down. Yes. So we can see the artery in longitudinal as Y-shape, while the deep femoral is deeper than the superficial. And we can assess in that images Doppler or grayscale images. For popliteal, in supine popliteal artery, we can evaluate it while the patient in supine position, but better usually to go for prone. In supine position, we have to abduct the knee joint and evaluate it in the posterior medial portion. And we can see also in the same image the small saphenous vein. In the prone position, we can see better image for popliteal arteries for sure, in longitudinal and short axis also. Below the knee, which is the most important, because most of the time, CT scan or cross-sectional images is not good evaluator for the below knee arteries. So ultrasound is the golden standard for the arteries, infrageniculate artery, infrageniculate part of the body. So we can see it in prone position and supine position. In prone position, we need to assess the posterior, mostly in prone position is the posterior tibial and peroneal arteries, while in the supine position, we can evaluate better the anterior tibial artery. So the arterial Doppler is have two advantages, which is give a lot of advantages for grayscale images, where we can see the detail of the anatomy. We can evaluate the wall, we can evaluate the intraluminal artery, and also color Doppler and waveform evaluation, which give us the physiological data for the artery, either proximal or in the same site of the examination. For grayscale, usually we can evaluate the arterial lumen and also the arterial wall. We can assess the atherosclerotic changes, either it is calcified or soft plaques. And we can also evaluate the arterial size, especially for endovascular treatment. We need to evaluate that to decide which size of balloon, which size of stent we can use for such patient. In arterial duplex ultrasound, which is the most important and the advantage, the most important advantage of the ultrasound is the Doppler. The initial image we can evaluate for the arterial system is either it is patent or occluded. So we can see this cross-sectional, the transverse image in the site of proximal superficial artery. We can see, for example, this deep femoral is patent and the other one is occluded. So this is a simple image we can take. Other images we can evaluate is the waveform other than the color form, and we will go through it. To evaluate all of that, color or Doppler waveform, we have to be familiar with the keyboard of the ultrasound. We have to know how to use the scaling system. We have to know how to use the color with the gain and also the power Doppler with the gain, and to know which depth, the size of the box we have to use in the color box, what is the scaling parameter and inversion system to use it in the ultrasound. So for color box, usually we have to evaluate it as superficial as we can, and we have to decrease the size of box as small as we can. And to evaluate the artery better, we have to decrease the angle of the box toward the flow of the artery. We call it as a stair. So stair, if we evaluating the artery, it has to be toward the flow itself. Other tool we have to evaluate is to change the color gain without displaying any background noise. And this bottom actually, it is different actually for ultrasound keyboards. We have to adapt it with our machine we are using because it is different from company to other. Sometimes color gain and grayscale gain came at the same bottom, and in other companies it will be separate. So we have to adapt it with the company we are using, the ultrasound companies. For velocity scale, we need to change it as we can change it as low as we can get the flow inside the lumen. So without also aliasing artifact or noise. So both gain and scale is important to handle or to change to get the better image without any noising or any aliasing artifact. So mostly we are increasing the gain. The gain is the image came beside the ultrasound box. So we have, for example, in this image, it is about 35 or 3.5, but if this is very low, we can get the lower flow by this scale system. But if it is normal, for example, normal vessel, we will have a lot of artifact around the vessel itself. So we have to adapt that parameters to get the better images without any artifact. So this is the best image after we manipulate or change the gain and also the scale to get that better. Mostly decreasing the scale and increasing the gain is the way to reach the best image. Inversion is something less important than the other parameters because since we have the flow, we can see the flow of the artery is blue in this image, while the same artery is red in the other image. So this is related to inversion. When we press the inversion button, it will take the opposite direction of the flow. It is depend on the flow of the artery or the blood toward the superficial to the skin. So it is just invert the direction of the flow, but no significant importance or for the evaluation of the artery itself. For the Doppler waveform, we have we have about 4 patterns of waveforms we can get from the artery itself. First, we have to select the center of the artery and change the angle of the cursor toward the flow. So if we will get that parameters correctly, we will have the best waveform for the arterial flow. So the normal waveform is we have to get rapid systolic acceleration with rapid deceleration, and also brief reversal in early diastolic and return antegrade flow in mid diastolic with the loss of antegrade flow during the late diastole. This is the normal arterial flow. If we lose any of these waveforms or all one of that patterns, this is abnormal, regardless is it important or not clinically. So we have the biphasic, we can see wider or slower acceleration. We can assess that by wider distance between acceleration and deceleration. And also we don't have any upstroke in the late diastolic. So we call it as biphasic. The normal is triphasic. So this is biphasic. The last 2 patterns is monophasic, but one of the in picture number C is higher upstroke. We call it as higher resistance, and in D is lower resistance, but it is monophasic. We have no diastolic earlier or later. So for example, if we have C in pedal arteries with higher resistance, so in patients with diabetes with no critical limb ischemia, or even with critical limb ischemia but high velocity, so it is no need for such patient to be treated endovascularly. So this is acceptable for such patient. But if has lower resistance, so such patient need to go for endovascular if he has critical limb ischemia. Biphasic sometimes seen in common femoral artery in atherosclerotic patient for femoral arteries all over, common or superficial, acceptable for atherosclerotic changes. So we have the peak systolic velocity. There is different informative actually articles in the literatures regarding how to evaluate the peak systolic velocities. One of the most useful one is the ratio. So the peak systolic velocity ratio, we are calculating and dividing the peak systolic velocity at stenotic area and peak systolic velocity for CM proximal to the stenotic area. And according to the ratio, we can decide or have an idea what is the degree of stenosis according to the ratio itself. Other literature articles, they mention we can go for example, for pedal arteries, we can go more than 40. Some opinions go with ratio between 25 to 60. A lot of ideas regarding that, but for the ratio has actually 3 or 4 articles regarding that ratio, which they have a lot of benefit for the patient to go into vascular or not, according to the stenosis degree. So regarding ABI, ankle brachial index, This tool is very informative, actually physiological, and give physiological information and easy to do in the clinic even. Usually ABI and also pulse recording volume, both can be done in the same session or in the same sitting in the clinic itself. So we are usually used with pressure cuff, measuring the systolic in brachial and in ankle areas, and take the ratio from the both systolic readings, and we can have an idea if the patient has any PAD or peripheral arterial disease or not, and we can also evaluate is it significant disease or not. So for ABI, as I said, it is straightforward to interpret, and also it is not difficult to perform. The measurement also of the ABI in asymptomatic patient with increased risk of PAD is considered reasonable by the same guidelines of AHI 2016. And this is how to do the ABI. We just take the systolic blood pressure reading in brachial artery, usually taken in both arms, and take the highest reading for systolic. And also for the right side, we assess above the ankle joint, the systolic reading also. And after we getting the ankle brachial index, we can classify the patient accordingly for how severe is his arterial insufficiency. Most of the patient, and about 1/3 of the patient, has calcified atherosclerosis, and they will have non-compressible artery. So their reading will be more than 1.4. So it is inconclusive for such patient. But for other patient, if it is the normal is more than 1 to 1.4, and also for borderlines, or we can just take it as 0.9 to 0.4 as arterial insufficiency, mild to moderate. Less than 0.4 is severe. And also we can classify the patient from 0.9 to 0.4 as claudicant patient usually. Less than 0.4 is the critical limb ischemia, including the wrist pain and tissue loss. As we said, most of the patient, 1/3 of the patient has atherosclerosis in diabetic patient or advanced chronic kidney disease. So we will not get any information for such patients from ABI. And also for CT scan is difficult to assess. So the ultrasound is the only tool usually to assess such patient. For pulse volume recording, so as I said, it is done in the same session of the ABI in the clinic, applying the cuff in the brachial arteries or brachial region. Also, we can take pressure cuffs in the upper thigh, mid thigh, upper leg, and above the ankle, and we can assess the waveform as we see in this diagram as and classified into 4 to 5 degrees. So the idea of the PVR is physiological information. It can be measured as changes in volume at the level of the extremity with cardiac cycle. PVR usually, as mentioned, is done with cuffs. And now there is a modern devices. It can measure both in the same site. When apply all of that cuffs, it will give us the reading of ABI and PVR in the same session. How to evaluate that waveforms? Usually the normal waveforms is, we can see the upstroke of the waveform with diacritic notch. We can see it, which is normal, and see mainly in the young patients, while the the patient with, we call it as inflection point in the arrow. It is normal also, but seen mostly in the elderly patient. So this is the normal appearance of the BVR, while the classification it is including 4, but now the new classification including 5. So we have the upstroke. This is the normal with dichrotic or inflection point. If it is decreased, it is mild, moderate, severe. And also we have plateau form, where is the occlusion is suspected in such patients. We call it as, we can put it at J, and it is plateau. So this is normal example of patient with ABI. We can see the evaluation of brachial. It is 1.2 ABI, and we go down to upper thigh. It is 1.2, 1.2, 1.1, 1.1, and the normal, the conclusion is 1.2. So this is normal evaluation of ABI. For BVR, we can see a stroke with dichrotic also in all waveforms, which is normal. The example for abnormal waveforms and ABI, as we can see, 1.5 for brachial. This is a systolic. Sorry. Yeah, this is for the systolic. And when you evaluate the ABI, it will be 0.9, 0.7, sorry, in the upper thigh. And it's going down. For this one is 0.9, which is normal, but in the other side, in the right side, is 0.5, which is mild to moderate arterial insufficiency. And we can see the abnormal waveform, which is moderate, mostly moderate for the waveform type of BVR. For for CT angiography, usually this kind of cross-sectional images is to evaluate the anatomical or morphological peripheral arterial disease. Usually need to use contrast. It is quick and readily available scan, and with high sensitivity and specificity for the lesion above the knee. Below the knee, we have issue, and there's a problem with the calcification for small arteries to evaluate either it is stenotic or not. There is new CT scan, dual energy CT scan, can evaluate such lesions by exclusion of the artifact from the calcium in the arterial wall. The disadvantage of the CT angiography is using of contrast. Most of the patients with diabetes has renal insufficiency. There is easier or preparation is become easier in such patient now, so it can be done up to 30% or 30 up to GFR 30 with IV hydration and close follow-up or observation of the patient for creatinine. For the allergy also, we have pre-medication to do that scan also. For MRA, it is unusual to be used. Most of the patients use MRA is the renal insufficiency, because we have an option called this time of light. We are not using gadolinium or contrast in such scan. We are dependent on the flow of the artery. The problem with the MRI is time and artifact, motion artifact. Most of the patient cannot adapt to the claustrophobic effect of the MRI. So, but it is better than actually CT scan in evaluation of below knee, because there is no susceptibility of to the heavily calcified vessels. And the disadvantage is the cost and time needed for such study. It is absolute contraindication to do for patients with implanted pacemaker or defibrillator. We have new technology called TREX for MRI with IV gadolinium, but usually it is done usually for the patient with venous or vascular malformation. We can see the kinetic behavior of the lesions, but there is no good information regarding the peripheral arterial disease or lower limb arterial evaluation. One of the side effects of the gadolinium in patients with renal impairment is the nephrogenic systemic fibrosis. We avoid that in if it is less than 30, and we usually divided the dose by 2 if we will use it more than 30 to 45 GFR. Two take-home messages for the evaluation of peripheral arterial disease, because we are seeing a lot of patients in radiology department for just to exclude peripheral artery disease. So I think if we apply ankle brachial index in clinics and good training for technologists or nurses there, I think we will get a lot of information from the clinic itself before going for radiological assessment. Ultrasound, I think this is a gold standard, better than CT even for evaluation of the arterial. So for the physiological information of the tubular ultrasound, we can have an idea if the patient has even proximal stenosis left from the common femoral artery itself. If we have, for example, triphasic flow in the common femoral artery, so this is an idea, it is open all over to the heart. I think if we have good moderator or good trainee for the ultrasound, so most of the patients, especially in diabetic centers, will get benefit from that. If you have any question.
Thank you so much, Dr. Saeed, for the